Hello, good morning to everyone. My name is Wilson Salburo, and I will be your facilitator for this session in the topic of emergency department nursing. First, I would like to thank everyone for attending this session, and to our speakers, thank you for accepting the invitation. Uh, I hope I know we will learn more about the about topics under emergency department more from you. To begin with, let us start with our first presenter. She has 15 years emergency room experience with certification on ACLS, PALS, ATCN, and currently a charge nurse in Sheikh Khalifa Medical City in Abu Dhabi, UAE. Let us all welcome and give our virtual round of applause to Miss April Romano Condoy. Ma'am April.
Yes, thank you, Wilson, for that brief introduction. So, good morning, everyone. Our presentation for today is all about emergency nursing. So, as an ED nurse for more than a decade now, working in this field is challenging and it requires a general knowledge of all medical situations. Cases are either emergent, urgent, and non-urgent, which still need clinical skills to intervene in any situation because ED is unpredictable. So to start our mini webinar, let us first define what is emergency and the types of emergency. So what is emergency? It is a serious, unexpected, and often dangerous situation requiring immediate action. Any situation that poses an immediate threat to a person's health, security, property, or environment. It is an urgent need for assistance or relief. So when we say medical emergency, it is a condition in which the onset is sudden and manifests itself by symptoms of sufficient severity, including severe pain, and the absence of immediate medical attention will result serious jeopardy to person's health, such as impairment to the person's bodily functions, dysfunction of bodily organ, or disfigurement. So there are examples of medical emergency. Number one is multiple injuries, or we have cases like major trauma due to rapid road traffic accidents, severe shortness of breath, like for example in patient with asthma, COPD, or those patients with airway compromise, loss of consciousness, sudden change in mental status or disorientation, severe bleeding, or example is the upper gastrointestinal bleed, acute pain, or those conditions requiring immediate attention. Example is acute myocardial infarction, appendicitis, poisoning, convulsions, and stroke. So these cases requires life-saving intervention so that they will not be jeopardized. Next slide. So according to World Health Organization, emergency they define as a state of emergency demands to be declared or imposed by somebody in authority who at certain moment will also lift it. Thus, it is usually defined in time and space. It requires threshold values to be recognized and it implies rules of engagement and exit strategy. Like for example, if there is a bomb explosion in a certain area, the command center will declare an emergency because of a huge number of casualties. So after solving the problem, they will lift it also. There are types of emergency. Number one types is biological emergencies. These are diseases as well as biological agents. Example includes outbreaks of epidemic diseases, plant or animal contagion, insect or other animal plagues and infestation. Biological disasters may be in the form of epidemic or pandemic. Like for example, in our current situation, COVID-19 virus is kind of biological emergencies. Chemical emergencies. When a hazardous chemical has been released and the release has the potential for harming people's health. Chemical releases can be unintentional as in the case of industrial accidents or intentional as in the case of a terrorist attack such as sarin or VX, those chemical warfare to harm people. Types of emergencies. Radiological emergencies is another kind. These are emergencies involving the release of radiation that could harm people's health, such as nuclear power plant accident, nuclear explosion, or dirty bomb. And the last one is weather and home emergencies. These are emergencies involving potential hazards such as winter weather, extreme heat, typhoon, flooding, or carbon monoxide. So in conclusion, knowing how to assess the signs that makes up an emergency will help to know how to handle it. Being well prepared for an emergency will pay off when it's time to handle any emergency situation. So thank you very much for listening.
Thank you very much, Ma'am April, for that wonderful presentation. Our next presenter uh, is originally from Sorsogon, Philippines, and is currently working as a senior staff nurse in emergency room theaters at St. George University Hospital in London. Let us all welcome Mr. Redin Destura. Sir Redin, you have the floor.
Good morning, classmates. Good morning, classmates, and good morning, everyone. So I was tasked to discuss all about triage. So triage is one of the widely used. Uh, I mean, this is one of the widely used method of classification of patient um, based on their based on their based on the severity of their needs. So we are all familiar with triage because during our undergraduate education, this was introduced to us, and especially for those who are practicing at the moment in the emergency department in the response team, this is widely being used. Next slide, sir. So triage is the process of prioritizing patients and treatment during mass casualty. So it is a system that we discriminate between rival patient needs, and we prioritize the needs based on the established parameters, which is the basic one, which is the airway, breathing, and circulation. The patients are classified according to the type and urgency of their condition, and we aim to put the right patient to the right place at the right time with the right care provider. To make it short, we are putting the patient's best interest as priority. Despite the inconsistencies in different countries between the guidelines of triage, it is defined as doing the greatest good for the greatest number. But triage is simply a sorting process that, when applied, create a situation that allows for doing the greatest good for the greatest number. So technically, the triage counter in the ED, or the triage officer within the field, is simply allocating a clinical priority rather than the diagnosis. The effectivity of the triage actually depends on how we classify the patient and how we deliver the necessary treatment for them. There are several key concepts of triage, which includes the resources are limited. So resources that includes human and material resources, especially in mass casualty and disaster events. The time for evacuation and help unknown or prolonged. So we should be aware of critical patient conditions, and especially during the time of wars and disasters, that the transportation of the patient needs to be considered as well. And do the most good for most patients using the available resources. So in this one, we utilize the utilitarian model to maximize the survival outcomes of the most people possible, which actually implies also the moral implication of triage, which is the palliative care, because sometimes as a triage officer, especially in the ED, it's hard to put a patient that says, oh, these patients will now need to have a palliation rather than a full resuscitation. So these are the key concepts and origin of triage. So it was first used during the Napoleonic War. So technically, it's a military in origin as well. And the attention is given to the first most habitual with most urgent conditions. Next slide, sir. So the objectives of triage are the following. So ensure that patients are treated in the order of their clinical urgency. That's why we need to make sure that we classify the patient accordingly. We ensure that treatment is appropriate and timely as per their needs. So allocate the patient to the most appropriate assessment treatment areas. So for instance, if in the UK, we normally put the patients whether they are in resus, in major, or in minor injury units. provide ongoing assessment of patients because the patient signs and symptoms can change over time, and to provide information to patient families regarding the services, expected care, and waiting times. This is to set the expectation that most patients, especially those that doesn't need urgent intervention, needs to wait a little bit more longer. And the last one is to contribute information that help define departmental activity, particularly the utilization of the facilities. So there are different types of triage. The primary one is the field. So this is the area that we apply the start and save principle, which is normally on disaster scenario. The secondary is the ED triage, which is the timely and appropriate on the emergency in the emergency department. And finally is the tertiary triage, which for those patients that are requiring specialist care, for instance, those in the ICU. Next slide, sir. So this is the differences of the ED triage and the disaster triage. So if you can see on the disaster triage, it is multiple points in time and it is dynamic. Rather, whilst in the emergency department, it is static and single point in time, because in the emergency department, we are following a rigid protocol, whilst in the disaster, it can actually change over time. Next slide, sir. So the patient categories, first one is those who will die no matter what.
Sir, sorry, you only have 1 minute left to wrap up.
Yeah, so this patient categories is actually part of the save category. So we have the start and the save. I would skip this slide for now. Next slide, sir. So the most widely used method is the start triage. So the start triage is the simple triage and rapid assessment technique. So we do this on the field, and it is done by the rescue personnel. So we actually classify the patient based on the categories of the response to the breathing, circulation, and their mental status. So this is the one of the pathway that we can utilize, and it's actually color coded already. So it's red, yellow, and green, which classifies how we will be able to treat the patient based on the urgency. Next slide, sir. So the SAVE triage, so SAVE stands for Secondary Assessment of Victim Endpoint. So when patients are ready to have significantly delayed transport from a scene, for example, is that number of casualties exceed transportation capacity or damage to hospital infrastructure, and it is helpful to identify patients who are most likely to benefit from the care available under alternative field conditions, for instance, in typhoons and among others. Next slide, first. So these are the common areas of assessment that we do to the patient. So we assess the vital signs, the airway, the chest, the abdomen, the pelvis, the spine. So yeah, so this is the areas of assessment that we do to the patient to classify them based on the urgency that they need. Next slide, sir. So this is the category of the SAVE triage, which is was shown earlier. So the category 1 is the patients who will die regardless of how much care they receive. The category 2 is patients who will survive whether or not they receive care. And the category 3 is patients who will benefit significantly from austere field conditions. So we classify whether they need palliative or delayed care, for example, for the non-urgent ones, and immediate care for those who will lose their life and limb if we don't give immediate care. Next slide, sir. So in the emergency department, it's actually almost the same, but the literature is saying that when we did a triaging on the field and the patient arrived in the emergency department, we need to redo the triaging for the reason that the patient condition can change over time. So different institutions, different countries are actually have different classification. For instance, literature that I found here, it's red, yellow, green, or black. But here in the United Kingdom, we are utilizing 5, which is red, orange, yellow, green, and blue. So it actually depends on where you work. So based on the hospital policies. Next slide, sir. So this is the example of color coding that we do in the emergency room. So we put the patient red if they are they need most urgent care. So the life-threatening shock or hypoxia is present or imminent, but the patient can likely be stabilized, and if given immediate care, will probably survive. The yellow one, which is the second in priority, are classified as urgent. These injuries have systemic implications or effects, but patients are not yet in life-threatening shock or hypoxia. Although systemic decline may ensue, given appropriate care, can likely withstand to 45 to 60 minutes. So I will skip the two one because it's rather self-explanatory. So I was also tasked to discuss about military triage. Military triage is actually almost the same as the normal triage. It's just there are variations. For instance, in the United States, where they have their echelon system, but generally, military disaster occur in civilian settings, and civilian disaster occur in military settings. Military triage simply means that the triage is done during combats or military operations. Next slide, sir. So this is the main difference of the military and civilian triage. So if you can see on the third category, there is the reverse triage situation, wherein the care provided to those who, when triggered, can quickly return to duty. Military situation, but could occur in a civilian mass call situation. Thank you, sir.
Thank you very much, Mr. Redin, for that very informational presentation. We'll proceed to our next presenter. She's a graduate of Medical Colleges of Northern Philippines, batch 2011, and currently a staff nurse in the emergency department of Cagayan Valley Medical Center. Let us all give our welcome to Miss Michelle De La Cruz Eslava. Ma'am
Good morning. So I am assigned to report about Incident Command Education Hospital Operation. So we have Incident Command System Objectives. We have to determine the roles and responsibilities of the incident commander and command staff. Second is to describe the purpose of unique position titles in ICS. Third is we have to describe the roles and responsibilities of the general staff. And then determine when it is appropriate to expand and contract the ICS organization. Identify the facilities used in ICS and their respective symbols. Types of incidents. Types of incidents. We have natural disasters, planned events, fire, both structural and wildfire, hazardous materials incidents, search and rescue missions, oil spills, planned events such as the Olympics, sport events, world leader conferences, etc. Distribution of humanitarian assistance, terrorist events, and natural disasters.
What incident command system?
What is ICS, or the Incident Command System? All Hazard Incident Management Concept. Number 2, it allows its users to adopt an integrated organizational structure. Number 3, it has considerable internal flexibility. Number 4, a proven management system based on successful business practices. And then number 5, the result of decades of lessons learned in the organization and management of emergency incidents. Next slide. Weaknesses addressed by ICS. Lack of accountability, including unclear chain of command and supervision. Then, poor communication, including system and terminology problems. Lack of an orderly systematic planning process.
Then,
No common flexible design management structure. No predefined methods to integrate interagency requirements into the management structure and planning process.
and then,
Overload incident commanders. No method to integrate interagency requirements. What is ICS designed to do? Meet the needs of incidents of any kind or size.
second,
Allow personnel from a variety of agency to meld rapidly into a common management structure.
and then third,
Provide logistical and administrative support to operational staff. Be cost effective by avoiding duplication of efforts. ICS has been tested in more than 30 years of emergency and non-emergency applications by all levels of government and in the private sector. CS position titles provide a common standard for all users. Distinct titles allows for filing positions with the most qualified individuals. Useful when requesting personnel.
yan ang command system position titles.
Avoiding combining positions.
How to avoid?
First is do not combine ICS position to save on staffing. Second, individuals may supervise multiple units, but the positions should remain distinct. Third is do not use non-standard titles or hybrid positions. Fourth is these titles may be unrecognizable to assisting or cooperating personnel. Fifth is avoiding combining positions. CS organizational components. We have section, division, group, branch, task force, strike team, and then a single resource. Maintaining span of control.
Third,
We have division, groups, branches. For division, we divide incident geographically led by a supervisor. For groups, describe functional areas of operation led by a supervisor. And then for branches, used when the number of divisions or groups exceeds the span of control and can be either geographical or functional led by a director. Maintaining span of control. Task forces mix resources with common communications, reporting to a leader. Strike teams, a set number of resources of the same kind and type with common communications, reporting to a leader. Single resources, individuals, a piece of equipment, and its personnel complement, or a crew or team of individuals. So that's all.
okay na.
Thank you, Ma'am Mitch, for that presentation. I'd like to remind everyone can you please double check your video and cameras. Okay, we'll proceed to our next presenter. She is a graduate of Lyceum of Apari and work at Apari Provincial Hospital as a nurse and now a proud and full-time mom. Let's all welcome Miss Rachel Dubla Jaime. Ma'am Michelle, Rachel.
Thank you, sir. The topic assigned to me was the Hospital Emergency Operations Plan. Hospitals are required to have an emergency operations plan, which describes how a facility will respond to and recover from all hazards. The plan should respond effectively to events that pose an immediate danger to the health and safety of patients, staff, and visitors. The plan is developed to assure availability of resources for the continuation of patient care during an emergency. The initial response to an emergency begins with recognition that an incident may or has already occurred. The plan provides the structure and processes that the organization utilizes to respond to and initially recover from an event. The process goes this way. The incident commander, after notification of the hospital disaster, activates and alerts the in-charges of different important areas of the hospital. The in-charges of various facilities in turn notify and alert the staff such as the medical, nursing, and other staff working in these areas to immediately reach the area and carry out their functions. The in-charges also call up the reserve staff which is not on duty to be ready in case they are needed. Next slide, sir. There are 9 key components on the emergency operations plan. First is the command and control. A well-functioning command and control system is essential for effective hospital emergency management operations. Some actions need to be done here is to activate the Hospital Incident Command Group or establish a supervisory body responsible for directing hospital-based emergency management operations. Next slide, sir. Second component is the communication. Clear, accurate, and timely communication is necessary to ensure informed decision-making, effective collaboration and cooperation, and public awareness and trust. An effective disaster response will involve communication with other local first responders. When formulating an emergency operations plan, a hospital administrator or manager should ascertain exactly which agencies will be handling an emergency and identify appropriate contacts there. Next slide, sir.
Third is the safety and security. Administrators must evaluate the potential safety and security hazards that may arise in any given disaster when implementing their mitigation plans. Hazardous and biological waste disposal instructions, biological or chemical decontamination procedures, and isolation protocols are all potential inclusion in a hospital EOP. Well-developed safety and security procedures are essential for the maintenance of hospital functions and for incident response operations during a disaster. Next, sir. The fourth is the triage. Maintaining patient triage operations on the basis of a well-functioning mass casualty triage protocol is essential for the appropriate organization of patient care. Next, sir. Key component number 5 is the surge capacity. Surge capacity is defined as the ability of a health service to expand beyond normal capacity to meet increased demand for clinical care. It's an important factor of hospital disaster response and should be addressed early in the planning process. Some actions needed here is we should designate care areas for patient overflow and increase hospital capacity by outsourcing the care of non-critical patients to appropriate alternative treatment sites. Next is the continuity of essential services. A disaster does not remove the day-to-day requirement for essential medical and surgical services, like the emergency care, urgent operations, maternal and child care that exist under normal circumstances. Rather, the availability of essential services needs to continue in parallel with the activation of a hospital emergency response plan. Next, sir. Seventh key component is the human resources. Effective human resource management is essential to ensure adequate staff capacity and the continuity of operations during any incident that increases the demand for human resources. If an organization intends to be operational throughout an emergency, it needs to identify from where it expects to acquire and restore its stock of non-medical supplies such as food, water, and clean beddings. Hospital administrators should document their inventory and its depletion rate to plan for lengthy periods without the ability to resupply. Next, sir. 8 is the logistics and supply management. The continuity of the hospital supply and delivery chain is often
an underestimated challenge during a disaster, requiring attentive contingency planning and response. Next, sir. The ninth component is the post-disaster recovery. Post-disaster recovery planning should be performed at the onset of response activities. Prompt implementation of recovery efforts can help mitigate a disaster's long-term impact on hospital operations. And that ends my topic. Thank you po.
Thank you very much, Ma'am Rachel, for that very detailed presentation. Now let's proceed with our next presenter. She is a nurse with more than 10 years of hospital experience and currently working in the emergency department in one of the reputable hospitals in Abu Dhabi, UAE. Let us all welcome and give our virtual round of applause to Miss Manilyn Gores Jumawan. Ma'am Manilyn.
Yes. Thank you for inviting me to be part of this lecture. Now I will discuss about the personal protective equipment in healthcare settings. Next, sir. Now, what is the PPE and why it is important to the healthcare professionals? PPE or personal protective equipment helps prevent the spread of the germs in the hospital. This can protect the people and the healthcare workers from infections. This is also a disposable clothing or a special equipment that we are being worn to create a barrier between you, germs, and the environment. PPE is also available to protect you from the exposure to infectious agents in the healthcare workplace that you are working to. And it is important also to know what type of PPE is necessary for the duties you perform. So we will be protected from ourselves and also from the others and from the germs. Next slide. What are the types of PPE? All of the PPE listed here prevent contact with the infectious agents or body fluid that may contain the infectious agent by creating a barrier between the worker and the infectious materials. Gloves protect us from the patients and from the environment. Gowns or aprons also protect the skin or our clothing. Masks and respirators protect the mouth and the nose. The respirator has been designed also to protect the respiratory tract from the airborne transmission of infectious agents. And now, one of the types of the PPE also that we are using is also goggles. This is to protect the eyes and the face shield and the entire face of ourselves. Face shields protect the face, mouth, and the eyes. Now, I'll be discussing about the factors influencing the PPE selection. When you are selecting PPE, consider the three key points. First is the type of anticipated exposure. This is determined by the type of anticipated exposure, such as touch, splashes or sprays, or large volumes of blood or bloody fluids that might be penetrate from our clothing. PPE selection is the combination of PPE, also in determining the category of the isolation precautions or the patient that we are handling to. Second factor is very much linked to the first one. This is the durability and appropriateness of the PPE for the task. So this will affect, for example, whether the gown or apron is the selected PPE are appropriate that we are taking to. So before going to the patient, let us think what kind of PPE that we have to use or prepare so we'll be protected from the patient or from the germs that we are being handling to from the infection. PPE must be fit in the individual user to ensure that all the PPE are be available in sizes appropriate for the worker that must be protected. Okay, let's move to the next slide, please. There are 4 key points to remember about the use of PPE. First, done before they have any contact with the patient, generally before entering the room. Once you have the PPE on use, it is carefully to prevent spreading contamination when you have completed your task. Remove the PPE carefully and discard the practicals provided. Then immediately perform the hand hygiene. This is the number 1 rule. Every time that you will do remove the PPE, you have to do the hand hygiene. Then in addition to wearing PPE, you should also use a safe work practices. Avoid contaminating yourself by keeping your hands away from the face and not touching, adjusting or touching the PPE. Also remove your goggles, the gloves if they are become torn, and perform an hand hygiene before putting a new pair of gloves. You should also avoid spreading contamination by limiting surfaces items touched by contaminated gloves. So now, briefly, I will discuss about the gowning and the doffing. The gown should be done first. Make sure that the respirator should be put on the necks properly adjusted to fit. Remember to fit check the respirator. The goggles or face shield should be done next and the gloves are done last. Keeping in mind that the combination of PPE use and therefore the sequence of donning will be determined by the precaution that needs to be taken. And then for the doffing, the proper of the removal of PPE is also be strictly followed to avoid the spreading of infection. To remove the PPE safely, you must be able to identify what sites are considered to clean and what are the contaminated. In general, the outside front and sleeves of the isolation gown and outside front of the goggles, mask, respirator, and shield are considered contaminated. So we should not touch this part. Regardless, whatever it is visible soil, also outside of the gloves is contaminated. So these things should be avoided to be touched. The sequence of removing PPE is intended to limit the opportunities for self-contamination. The gloves and other are considered the most contaminated pieces of PPE. So gloves, these are the most contaminated. Just remember this one. Therefore, it should be removed first. The face shield or goggles are next because they are more cumbersome or would be interfere with the removal of PPE. The gown is the third sequence to be removed. Then the last is the mask or respirator. The location for removing of PPE will be depend on the amount and the type of PPE worn and the category of the isolation that the patient is on, if applicable. If only gloves are worn as PPE, it is safe to remove and discard them in the patient's room. When gown of full PPE is worn, PPE should be removed at the doorway or the anteroom of the patient. Respirator should always be removed outside the patient room after the door is closed. Hand hygiene should be performed after all the PPE is removed. So the key point of this is to protect ourselves and our patient and the environment, and also to do the hand hygiene. This is very important, and this has always been highlighted to anything that we are being do to any task. Thank you for listening.
Thank you very much, Ma'am Mandeline, for that very wonderful presentation. I bet we all learned new things about protective personal protective equipment. Okay, let's move on to our last presenter for this session. She is a graduate of St. Paul University, batch 2005 BSN program, and has about 15 years of experience in pre-hospital setting as a field medic, and currently working in the ambulance department of the Emergency and Public Safety Directorate of the Abu Dhabi Police, United Arab Emirates. Let us all welcome Miss Daisy Jane Garces. Ma'am Daisy.
Thank you, sir. Thank you for having me as one of the presenter. My topic for today is about blast injuries. So to better understand about blast injuries, I wanted to discuss about explosion. Next slide, please. So explosion is a result of rapid transformation of solid liquid chemical substance into gas, which is released at high pressure and temperature into the surrounding. It can produce specific injury patterns and the potential to cause life-threatening multi-system or multi-dimensional injuries in people at the same time. So explosion is categorized by the following. It is high-order explosive or HE, low-order explosive or LE, and manufactured explosive and NE. In high-order explosives has a strong supersonic pressure wave known as the blast wave or shock wave. Example of these are TNT, Semtex, nitroglycerin, and dynamite. High-order explosives are designed to cause large and rapid rise blast pressure, while in low-order explosive only create subsonic explosion and lack of a high overpressurization rate. Example of low-order explosives are pipe bombs and gunpowder. While on manufactured explosive, this is exclusive high order explosives that usually implied in standard military manufactured weapons. In addition to the blast wind, explosion can cause blast wind. So blast wind is a flow of superheated air that can interact with people and objects and cause injury or damage. Remember that in close confined space, there is more damage, death, and blast injuries than open space. And in underwater blast injury, it is more devastating at greater distance because pressure wave travel much faster in water. Next slide, please. So blast injuries are the special form of trauma. Special form of trauma in environmental pressure originating from explosion. Severity of injuries pattern after blast are depends on the following: composition and type material involved, the delivery method involved, distance between the victim and the blast occurred in closed or open space, and surrounding environment and weather hazard. There are 4 categories or types in mechanism of blast injuries. Next slide, please. So the first is the primary. So primary is unique to high order explosive. It is a result from the impact of the overpressurization wave with body surfaces or the blast wave. So the body affect to primary mechanism of blast injury are gas-filled structures are most susceptible, like lungs, GI tract, and middle ear. Usually, the type of injuries are blast lung or pulmonary barotrauma, tympanic rupture and middle ear damage, abdominal hemorrhage and perforation, globe, eye rupture, concussion without physical signs of head injury. While in secondary, it is result from flying debris and bomb fragments. Any body parts can be affected, like the limbs, the skin, the head. And the type of injuries in secondary is penetrating or ballistic fragmentation or blunt injuries. And in tertiary, next slide, please. This is a result. Go back, sir. This is a result from individual being thrown by the blast wave, and the body affected parts are any parts of the body, and the type of injuries are fractured or traumatic amputation, closed and open brain injury. And for the last one, the quaternary, it is all explosion-related injuries, illnesses, or diseases not due to primary, secondary, or tertiary mechanism, include exacerbation or complication of existing condition. So any body part is affected, and the type of injuries are burns, crush injuries, closed and open injury, asthma, COPD, or other breathing problems from dust, smoke, or toxic fumes, angina, hyperglycemia, or hypertension. Next slide, please. So I have here the general incident management for blast injury. So first one is secured the same SIP is safe because initial blasts are often followed by second blast, either by design to cause further destruction or as a result of secondary fires which break out following the initial blast. So next is Palo Hospital and Regional Incident Command Plan. Next is expect for an inverse triage. which means that the most severely injured arrive after the less injured, who bypass EMS triage and go directly to the closest hospital. And expect as the management of the scene progresses, there are more injuries and it's become more worse. Next is double the first hour's casualties for rough prediction of total first wave of casualties. And obtain and record details about nature of the explosion, potential toxic exposure, and environmental hazards, casualty location from police, fire, EMS, ICS commander, regional EMA, health department, and reliable news sources. And lastly, if structural collapse occurs, expect increased severity and delayed arrival of casualties. And that's end my report. Thank you for listening.
Thank you very much for the presentation, Ma'am Daisy. For the open forum, we can only accommodate, I think, 2 questions because we are already uh, beyond 45 minutes. So, any questions for the speakers? Are there any questions? Ma'am Joanne, do you have any questions? Sir Kurt, okay, Sir Kurt, can you turn your mic, please? And just address to whom you're gonna address the question. Just mention.
This question is addressed to Ma'am Rachel. The question is, do you think that doing drills of the plan is important? Addressed to Ma'am Rachel.
Ma'am Rachel?
Yes, sir, I heard it. Yes, sir, I think doing drills is important. Once an emergency operations plan is written, it must be practiced and if necessary, be modified in response to feedback. These drills are also key components in the emergency preparedness, and these dry runs are will help us identify the pitfalls and areas that needs to be improved.
Sir Kurt, does that answer your question?
Okay, sir. Thank you, Ma'am Rachel.
Ma'am Rachel, thank you for that. Ma'am Joanne, would you like to ask questions to our speaker?
Yes, sir.
To whom you're gonna address the question?
I would like to address my question to presenter number 2, Sir Redin Destura. So what? Okay.
Sir Redin?
Sir.
Can you turn your mic, please? Okay, Ma'am Joanne, please proceed.
Yes.
Sir, what are the implications of COVID-19? Yes, sir.
Okay, Ma'am Joanne, please proceed.
Okay. What are the implications of COVID-19 pandemic and the high demand for ventilators?
Ano po yun?
I think there's a delay in the transmission of the audio. Ma'am Joanne, can you say the question again?
Hello, can you hear me, sir? Hello? 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 Hello?
Ma'am Joanne?
Yes,
okay.
ma'am.
Okay.
My question is, what are the implications of COVID-19 pandemic and the high demand for ventilators and scarce resources in the triage of patients requiring specialized care?
Sir Redin, did you manage to hear the question?
So basically, in the COVID-19 pandemic, there is a very high demand for ventilators. Yes, sir. Yes, sir. I did. Can I answer it, sir?
Yeah, please proceed, please.
Yes. So basically, the COVID-19 pandemic have put a lot of demands for ventilators at the moment. So we are expecting that hospitals will have to allocate the resources to the most to the patient that actually needed the most. So basically, there is a international consensus that we will we will allocate the ventilators to those who have the best chance of surviving. In the literature, there's a very limited information about this. But then in the European side, we actually allocate the ventilators to those who have higher chance of survival. Um, so basically, there is a ethical question here about equity and maximizing benefits, because sometimes, you know, there is a first serve principle that those who came first will be allocated with the ventilators. But then, because the resources is very scarce, we need to like conduct a proper assessment to those whom really the patient that really needs, so that, you know, the prognosis of the patient needs to be really considered. So I think that's the best implications of COVID-19 current issue of scarcity of ventilators. I hope that answered your question, ma'am.
Well said, sir. Thank you so much.
Thank you very much, Sir Redin, for answering that question. I think we can just entertain one more question, just one more, and we will end the session. Ma'am Renalyn, do you have any question? Any questions, Ma'am
Hi,
Renalyn?
everyone. Okay, sir, I have one question pertaining to Ma'am Daisy regarding blast injuries. In a blast incident, who usually is in charge of making the scene secured and declaring that the scene is already safe?
Ma'am Daisy, please.
Yes. Based on my experience here in UAE, usually the in charge is the Explosive and Ordnance Division under police or civil defense. Actually, here in UAE, I haven't responded to actual blast injuries, but we always had the bomb threat. So usually they are the one who arrive at the scene to secure or to just know if this is really a bomb or anything. So they are the one who arrive the scene, secure the scene, if it's safe for us to go or not. I hope I answer your question. Thank you.
Thank you, Ma'am Daisy. Ma'am
Thank
Renalyn,
you, ma'am.
does that satisfy your question?
Yes, sir. Very well said po.
Thank you very much. We would have 5-10 minutes break, and we will proceed to our second session after the break. Hope you still be joining our second session.
Okay, sir. Thank you.